endometrium, such as uterine cycle. Normally, the antral follicle, due to the influence of follicle stimulation hormone, start growing. This is the follicular phase of uterine cycle due to the secretion of estradiol by the cells of growing follicle. If we have an ideal menstrual cycle, on 14 and 15 days of this menstrual cycle, due to the peak of LH in pituitary gland, we have an ovulation. The ovum passes to the abdominal cavity and then passes, due to the febrile movements, into the uterine tube. After the rupture of the follicle, we have corpus luteum. You know that the corpus luteum produces progesterone. This is the main hormone which have influence, and this is the luteal phase of menstrual cycle, and this is the main hormone of pregnancy if this couple wants to have their baby. If there is no fertilization of an ovum, and if we have no pregnancy, corpus luteum starts to be corpus albicans, and then menses starts once again. That's why we have 3 phases of uterine cycle. The first phase is menstruation, then follicular phase, then luteal phase. The main courses says about the ovulations like a separate phase of menstrual cycle. It will be correct if you say that we have 3, for example, without an ovulation phase, or we have 4 phases of an uterine menstrual cycle, such as follicular, ovulation, luteal, and menses. It's very important to know the physiological changes in the female organism due to the hormonal influences of pituitary gland, because it's easy to you to diagnose pregnancy in the future. For a woman with regular menstrual cycles, I pay your attention that she should have regular menstrual cycles, a history of 1 or more missed periods following a time of sexual activity without effective contraception strongly suggests early pregnancy. That's why if women come to you and says, "Doctor, sorry, there is no period," the first thing you should think about pregnancy, and you should exclude pregnancy like a reason of missed menstruation. What are the main signs and symptoms of early pregnancy? Amenorrhea or missed period. Maybe nausea with or without vomiting. Also, breast enlargement and tenderness of the breasts. But it's not obligatory sign and symptoms. These signs the woman also has during an insufficiency of luteal phase of menstrual cycle. But in the majority of women, breast enlargement and tenderness are one of the signs and symptoms of early pregnancy. Also, due to the influence of progesterone on the muscles of urinary system, it may be increased frequency of urination without dysuria and a fatigue, also an early symptoms of early pregnancy. What can you see during a physical examination? What can you see? Who have their classes? On your classes, our professors and associate professors and assistant of professor teaches you by manual investigation and a speculum investigation. During this procedure, you can see the signs of early pregnancy. For example, during by manual examination, the pregnant uterus start to be softening and slightly enlarged, starting from the 6 or 7 weeks of pregnancy. What else? During the speculum examination, you can see a congestion and bluish discoloration of the vagina, such as Chadwick signs. This is also the sign of an early pregnancy. Also, during a bimanual examinations, you can palpate such as softening of the cervix. This is Haga sign. Also, during an examination, you can see increased pigmentations of the skin. Appearance of circumlinear stria on the abdominal wall in their late stages of pregnancy, such as stria gravidarum, also can help you to diagnose. Of course, in the late term of pregnancy, using an obstetrical's grips, you can palpate the fetal parts, and appreciation of fetal movement and fetal heart tones during an auscultation using an obstetrical stethoscope. In my classes, I showed the colleagues this instrument, and they had a possibility to hear the fetal heart tones. And of course, you can see in the late term of pregnancy the fetal movement. This is, for example, during bimanual investigations on the left picture, you should do it using two arms. The softening of the uterus, the enlargement of the uterus, also the softening of the cervix, such as Haga signs, can help you in the diagnosis of early stages of pregnancy. Of course, in the late terms of pregnancy, on the upper right picture, you can see stria gravidarum. Usually you can see in primigravida such signs. Using obstetrical grips, on this picture you can see clearly the second obstetrical grips. The doctor can determine their position of the fetus, the view of the fetus, and can palpate where their back and where the small part of the fetus. Of course, You can do it if you have the late term of pregnancy, and it's clear to understand that these grapes is impossible to use in the early stages of pregnancy. Also, using the measurement of the uterus fundus height, you can tell what is the term of pregnancy has such woman, but approximately, of course. If you measure if the height is between the distance of the upper part of the pubis and the umbilicus, it's easy to remember that this is 16 weeks of pregnancy. If you have the height of the uterus fundus in the level of umbilicus, this is usually 12 or 12 weeks of pregnancy. The height of the uterus between the umbilicus and costal arcus, this is 28 weeks of pregnancy. The highest uterus fundus height is at 36 weeks of pregnancy. During an external examination, during the external measurement, the measuring of the height uterus fundus can help you to understand what is the week of pregnancy has this pregnant woman, especially if she doesn't remember the first day of her last menstrual period. I think it's easy. Let's talk about pregnancy test. What is this and what is the main goal of these tests? The pregnancy tests is the determining of the human chorionic gonadotropin HCG test, alpha or beta subunit, the ECG produced only in the pregnancy and produced in the syncytial trophoblast. You can determine ECG in urine. It's common. In my opinion, each woman can do such test. And the serum in the blood. Of course, usually the doctor administrates woman to determine ECG in the blood. In urine, approximately 4 weeks following the first day of the last menstrual period, all urine pregnancy tests are best performed on early morning urine. It's obligatory conditions for determining early morning urine specimens, which contains the highest concentration of HCG. Of course, she can use and do these tests during a day, but it can be not positive or slightly positive. That's why you should pay attention of women that it will be better if she do such test early in the morning with early morning urine specimens. Of course, pregnancy test is more specific and sensitive in the blood. By following serial quantitative HCG level and comparing them with the expected rise derived from normative data for proven normal intrauterine pregnancies. On this picture, you can see urine test in most normal pregnancies at HCG levels below 1.200 milliliters unit per milliliter. The HCG usually doubles every 48 or 72 hours, and it normally increased by at least 60% every 2 days. This is the rules of enlargement of HCG, and usually I ask about it on exam. Please remember that the HCG usually doubles every 48 or 72 hours. For example, she has the first HCG, for example, 400. When she comes the next, after 48 hours, the results should be what? Of course, not less than 800. What does it mean? It means that she has progressive intrauterine pregnancy. In case if the enlargement is less than doubles, this may be an extrauterine pregnancy or a miscarriage in an early stages of pregnancy. How can we determine also in early stages of pregnancy? Of course, using their modern technologies and with using of an ultrasound machine. Abdominal ultrasound allowing visualization of a normal pregnancy gestational sac 5 to 6 weeks after the beginning of the last normal menstrual period. Of course, a transvaginal ultrasound is more specific and usually detects pregnancy at 3 to 4 weeks of gestation. And usually in an early stages of pregnancy, we use an ultrasound by transvaginal. On this picture, you can see an ultrasound images of an early stages of pregnancy. On the left picture, or an ultrasound image, you can see the gestational sac containing a yolk sac, and you can see an early embryo. The yolk sac is the circular hyperechoic structure adjacent to the embryo. On the right picture, you also see an early gestational sac, demonstration the early embryo. Calipers are placed at both ends of the embryo, measuring the longest length from the crown to the rump, giving the crown rump length. This measurement is used for dating the pregnancy. Detection of fetal heart activity, such as fetal heart tones. Of course, if you have an early stages of pregnancy, it's impossible to detect the fetal heart tones by the stethoscope. Usually we use an ultrasound with the Doppler. An electronic Doppler devices can help you to detect fetal activity approximately from 12 weeks of gestation. And by using of an acoustic stethoscope beyond or in the inner left picture, This is an electronic auscultation machine which also help us in detection of a fetal heart activity, can help you to diagnose progressive or non-progressive pregnancy and to determine the heart rate for avoiding distress of the fetus. How can we diagnose? Of course, you know the detection of human chorionic gonadotropin in the urine or blood can help you in the diagnosis of pregnancy. Also, an identification of pregnancy by ultrasound examinations. You know from my previous slide that in early stages of pregnancy, you should use a transvaginal ultrasound examinations, and in the late terms of pregnancy, it's easy to detect it by a transabdominal ultrasound. Identification of fetal cardiac activity with using of a Doppler during an ultrasound examination. What is abnormal pregnancy? We talking about abnormal pregnancy in case of spontaneous abortion, in case of ectopic pregnancy, or in case of trophoblastic disease. The most common signs and symptoms of pregnancy are amenorrhea or missed menstrual period, maybe nausea and sometimes slight or sometimes severe vomiting, breast tenderness, urinary frequency due to the influence of the progesterone, the main hormone which support the pregnancy, and the fatigue. The most sensitive methods of detecting the early stage of pregnancy is detecting ACG or such as serum pregnancy test. Almost all pregnant women will have a positive urine pregnancy test 1 week after this first day of a missed menstrual period. The diagnosis of early pregnancy is based primarily upon laboratory assessment of human chorionic gonadotropin, identification of pregnancy by ultrasound examination or identification of fetal cardiac activity by Doppler ultrasound are alternative methods, but sensitivity depends on the gestational age. Transvaginal ultrasound examinations can visualize a gestational sac at 4.5 to 5 weeks of gestation. What is prenatal diagnosis? What does it mean and why we talk about it on my lecture? Prenatal diagnosis can help us, you know, that normally we have 23 pairs of chromosomes. And prenatal diagnosis can help you to detect in time many genetic disorders and birth defects. You know that more than 200 single gene disorders can be diagnosed. Testing done only when a family history or other risk of chromosomal pathology. Prenatal diagnosis is the science of identifying structural or functional abnormalities, birth defects in the fetus. It's very important because during a pregnancy we need to avoid a delivery of the fetus with congenital malformations, because this is also not, in my opinion, not only medical aspects, this is also the social aspects of life. Etiology of birth defects: malformation, deformation, disruption, and other birth defects. What is malformation? An intrinsic abnormality programmed in development regardless of whether a precise genetic etiology is known. For example, the example wide spreading type of malformation is spina bifida. And on the right picture, you can see the newborn baby with the spina bifida. This is the malformation. For example, the spinal cord. What is deformation? The deformation caused when a genetically normal fetus develops abnormally because of mechanical forces imposed by the uterine environment. The normal limbs that develops contractures because of prolonged polyhydramnions. This is the deformations. For example, the deformations of the fetus leg due to the prolonged polyhydramnions. What is disruption? Which is a more severe change in form or function that occurs when genetically normal tissue is modified as the result of a specific insult. An amniotic band causing a cephalocelia or limb reduction abnormality. This is a disruption. Other, such as syndrome of trisomy of an 18 pair of chromosomes, polyhydramnions leading to pulmonary hyperplasia, and associations such as VATE. What does it mean? Vertebral defects: V, A, anal atresia, T, tracheoesophageal fistula with esophageal atresia, and R is radial dysplasia. Easy to remember. Association with weight. How can we determine what is prenatal and diagnostic? It can be three types: non-invasive, minimally invasive, and invasive. That's why we have three types of such techniques which help us in prenatal diagnosis. Non-invasive techniques by using an ultrasound and in a very rare cases by a strictly indication we use MRI because in our country the MRI is contraindications for the pregnancy, but in a very rare cases we can use it maybe in a difficult types of pregnancy, or if it's unclear to diagnose by an ultrasound and blood test. In a rare cases we use an MRI like a non-invasive technique in a prenatal diagnosis. Ultrasound. Non-invasive uses reflected sound waves converted to an image. Transducer placed on abdomen The transducer placed on abdomen also see physical features of fetus, not chromosomes. And may ID some chromosomal abnormalities by physical features. On this picture, you can see the examples of an ultrasound On the upper picture, you can see a 3D ultrasound of the fetus. In the inner, this is a 2D, an ultrasound examination of the fetus. On this picture, you can see cleft lip and palate. This is a ventriculomegaly. Also, it's if you are a good an ultrasound specialist. This is their fetus malformation of a nervous system. This is posterior urethral valve. Also, this is a not normal an ultrasound image. This is the diagnosis of malformations of urinary system. Multicystic dysplastic kidney. This is a 3D, 4D and ultrasound images. It's easy to diagnose their spinal cord. Minimally invasive techniques. This is cell-free fetal DNA. And pre-implantation genetic testing, such as PGT. What is fetal cells in maternal circulations? This is types of placental cells, white blood cells, and immature red blood cells with nuclei. Enter the bloodstream from 6 and 12 weeks. Fetal cells only 1 per 100,000 in mother's blood. Techniques needs to be developed. What is PGT? Pre-implantation genetic testing. It may be eggs collected, fertilized, allowed to develop. The third day of fertilization, embryo has from 6 to 8 For PGT, one cell sebrostomia is removed. For PG, DNA extracted and tested, and embryo without genetic disorders are implanted into mother. On this picture you can see the embryo, 1, 2, 3, 4 blastomere, and one blastomere can remove for pre-implantation genetic testing. Invasive techniques. What is this? This is chorionic villus implant, such as CVC. This is amniocentesis and percutaneous umbilical blood sampling, such as chordocentesis. What does it mean, amniocentesis? This invasive procedure can diagnose more than 100 disorders. Cells analyzed for chromosomal and biochemical disorders. Of course, during this procedure, it's an invasive procedure, and this procedure can enlarge the risk of infection and spontaneous abortion. Normally, we use this procedure when advanced maternal age, history of chromosomal disorder, parent with chromosomal abnormality, and mother carrier with X-linked disorders. You can see that this procedure we can use due to the strict indication. On this picture, you can see the amniocentesis procedure, a removal of about 20 milliliters of amniotic fluid containing suspended cells that were sloughed off of the fetus. Then biochemical analysis of amniotic fluid after the fetal cells are separated out after a centrifugation. Then fetal cells are removed from the solution. Analysis of fetal cells to determine sex. And then cells are grown in an incubator. And then doctor will do a karyotype analysis. What is chorionic villus sampling? Done for similar reasons as amniocentesis. Performed earlier than amniocentesis. Karyotypes available within a few hours or days, but of course this procedure, due to the invasive character of this procedure, of course increase the risk of spontaneous abortion. This is how can the doctor do this CVC procedure. You can see clearly this procedure on this picture. Neural tube defects. For example, anencephaly, spina bifida, cephalocelia, and other rear spinal fusion abnormalities. One of the detections of fetus abnormalities also a detections of level of alpha fatty protein in metalum, serum, and amniotic fluid. The high level of alpha fatty protein AFP in maternal serum and amniotic fluid is characterized in a case of a neural tube defects. Maternal serum alpha on this diagram, you can see the different levels of alpha fetoprotein in the serum. On this screening influence such factors: maternal weight, gestational age, of course multifetal or monofetal gestations, and such pathological conditions like diabetes. What is alpha fetoprotein? What is this? This is a glycoprotein of unknown functions. It used for biochemical screening for open neural tube defects in a week of 15 or 22 weeks of gestations, and also this protein is used to screening for trisomy of 21. Evaluation of maternal serum AFP elevation for genetic counseling. Also another diagnostic tests, for example a specialized sonography and such invasive procedure like amniocentesis. What is specialized sonography? Transfers and sagittal images of the spine and increasingly used to characterize the size and location of spinal defects. I showed you there an ultrasound images, 3D or 2D or 3D, 4D and ultrasound images. On these images, you can see clearly their spinal defects, their characteristics, size and locations. It's easy if you have a good ultrasound machine and if you have a good experience and good knowledge in it. Look at this picture. On the upper picture, you can see the changes in the fetal heart. This is an anencephaly. It's during an ultrasound investigations of the fetus, you can determine such malformation. In a transverse image, the inner left image, you can see the defect in the spinal cord. This is a spina bifida. And on the inner right picture, you can see the problem with the fetus cephalic. You can see the cephalocella. Amniocentesis. During this procedure, you can determine the amniotic fluid of AFP level and assay for acetylcholine esterase. Aneuploidy. What is aneuploidy? It can be autosomal or sex chromosome. In case of autosomal, you can diagnose Down syndrome. This is a trisomy of 21 pair of chromosome. Edwards syndrome. This is trisomy of 18 chromosome. And Patau syndrome. This is trisomy of 13 pair of chromosome. In case of sex chromosome, you can determine Turner or Klinefelter syndrome. On this picture, you can clearly see the Down syndrome. How can you determine during pregnancy? In the first and the second trimester, you can use sonography and a maternal serum markers. Or if you have changes on these diagnostic matter, you also can do an amniocentesis with the karyotype of the fetus, on which you can clearly see the problem with the 8 pair of chromosome. In this case, you have 3 chromosomes, normally usually 2 chromosomes. Second trimester screening, such as triple test, maternal serum alpha fetoprotein, HCG or free beta subunit of ACG, and unconjugated estradiol. Such as quadruple tests plus dimeric inhibin alpha, triple test plus INH. This is a quadruple test. Second trimester maternal serum screening for aneuploidy, performed at 15-20 weeks. In case of singleton gestation, adjust age based on level of AFP, HCG, unconjugated estriol or inhibin A, and positive screening rate is 5%. Unconjugated estriol. it synthesized from DHEAS converted to 16 alpha OH DHAs in fetal liver and then to unconjugated estriol by placenta. The low levels of this hormone are usually associated with the Down or Patau syndrome in case of triploidy, in case of steroid sulfatase deficiency, in case of fetal demise or congenital adrenal hyperplasia. Inhibin A polypeptide hormone secreted by granulosa and Sertoli cells, in pregnancy secreted by fetoplacental units, peaks at 8 to 10 weeks, then decline until 12 and rises gradually until term. Maternal serum screening. What are the advantages? Of course, a maternal serum screening avoids an invasive tests, avoid potential for fetal loss, identify a fetus risk. What is limitation? Provides a wide risk assessment, not a diagnosis. The sensitivity, of course, less than 100%, misses other chromosome abnormalities. And of course, disadvantages, this is an anxiety of the patient and a false reassurance. First trimester screening. Between 11 and 14 weeks, metallum serum analyte screening, also sonographic knuckle translucency, such as NT, and combination of both. Pregnancy-associated plasma protein A, this is a glycoprotein of an unknown function, only reliable for detection of these between 10 or 13 weeks, and the highest detection rate of any marker. First trimester screening. Advantages. Sensitivity comparable to cohort screen. It can be performed earlier if positive options of CVS, options of earlier TAB fetus affected, and increased privacy. Disadvantages does not test for novel tube defects. On this picture, you can see the normal length of the knuckle translucency in a 12-week of pregnancy. Normally, it not more than 2 millimeters. In case of Down syndrome, on the right picture, you can see the enlargement of the head of this NT, and this is one on an ultrasound signs of Down syndrome. CVC or amniocentesis. CVC performed at 10 or 12 weeks, but amniocentesis is performed at 15-17 weeks of pregnancy. Of course, results available earlier. In case of amniocentesis, we wait during 2 weeks for results. May lower anxiety in case of CVS. Its privacy if result abnormal option of early TAP preferable to some couples. And in case of amniocentesis, you also can detect an alpha fetoprotein at amniotic fluid for neural tube defect. What are another markers? It's the measurement of a nasal bone, frontomaxillary facial angle, also a ductus venosus or tricuspid regurgitation. The measurement of the nasal bone on this picture. On the left picture, the nasal bone present in an euploid fetus in the first trimester. And on the left picture, you can see the absence of nasal bone in case when the fetus has a Down syndrome in the first trimester. Using here 3D, you can see bilateral nasal bone present. Ductus venosus. When you use a Doppler during investigation of a pregnant woman, you can see a small sample volume and a high whip speed. This is a FMF angle in case of trisomy or Down syndrome. It increased. And also a tricuspid regurgitation, one of an ultrasound signs of Down syndrome. Be aware, gestational age affects the accuracy and less sensitive in younger women. Strong association between increase in knuckle translution and fetal cardiac anomalies. The knuckle translucency measurement is 3.5 millimeters or greater with a normal fetal karyotype, then target sonographic examination, fetal echocardia, or both should be considered. Sonographic screening of aneuploidy, major structural defects and soft signs. Diagnostic techniques. The second trimester amniocentesis, maybe early amniocentesis, chorionic villus sampling, fetal blood sampling, fetal tissue biopsy, preimplantation genetic diagnosis or testing, and fetal cell in the maternal circulations. The other methods of diagnostic of a fetal heart sound and rate, this is CTG. The CTG, can be antenatal or intranatal. On this picture, you can see the normal antenatal CTG. The features of a CTG, this is baseline, short-term variability, also accelerations, decelerations, and response to stimuli. What is this stimulation? This is contraction of the uterus or a fetal movements. Baseline fetal heart rate. It's 110 to 150 at term, fasting and early pregnancy. Below 100, this is baseline bradycardia. Below 80, this is a severe bradycardia. Tachycardia common with maternal fever and tachycardia with a reduced CTV. This is an early high signs of hypoxia of the fetus. Accelerations must be more than 15 beat per minute and 15 seconds above baseline. should be 2 per 15-minute periods. Always reassuring when present, may not occur when fetus is sleeping, should occur in response to fetal movements or fetal stimulations. Non-reactive periods usually do not exceed 45 minutes. Less than 90 minutes and no acceleration is worrying about the acute hypoxia of the fetus. Short-term variability should be more than 5 beats per minute. The most important feature of any CTG is a reflection of competing acceleratory and deceleration SNC influences on the fetal heart, and therefore represents the best measure of CNS oxygenations, will be affected by drugs, will be reduced in the preterm fetus. What is decelerations? We have early, rate, or variable deceleration. Early, this is mirrors the contraction. Late follows every contractions and exhibits a slow return to baseline, and variable show no relationship to contractions. In practice, many decels or dips are mixed. On this CTG, you can see the decelerations after the uterine contractions. This is dip 1, which can help you, and in this case we know that the fetus has a distress during the delivery. Also, the type of abnormal antenatal CTG, you can see the decelerations, and also in case of fetal distress. Abnormal CTG fetus, reduced CTV, no acceleration, deceleration after most contractions with the slow return to baselines. In practice, a CTG is best regarded as a screening tool, but high negative predicted value, poor positive predictive value. Therefore, the CTG should always be interpreted in its clinical context and backed by fetal blood sampling. The Royal College of Obstetricians and Gynecologists have their own classification: normal, when all 4 features are reassuring; suspicious, 1 non-reassuring feature; and pathological, 2 or more non-reassuring fetus or abdominal pattern. Non-reassuring features of a CTG: baselines, CTV, early deceleration, variable decelerations, a single prolonged deceleration up to 3 minutes. A CTG is abnormal when baseline is less than 100 or more than 180 beats per minute. Late decelerations are repeated. Atypical variable decelerations occur. 2 prolonged decelerations for more than 3 minutes occur. Sinusoidal pattern more than 10 minutes. This is all what I want to tell you in my lecture. Hope my lecture helps you in your everyday practice, and you can determine the pregnancy at an early stages and the late stages using a various tests or instruments. I wish you good luck Thank you for your attentions. Take care of you. Be healthy, wealthy, and wise. See you on the next lecture. Bye bye.
У вас какое время?
15:40, 17:20.
Вот, 15:40. Изменить. Доступ по ссылке. Теперь открытый доступ. Теперь ОК.
Да,
Хранить.
появилось.
Так все, у вас нормально. Там просто старое, я не знаю, как ее убирать, блин. Толком. Вот тут не было старой.
Да, ну теперь звук включить. Или вы уже включили?
Еще не начали эфир. Вот начать эфир сейчас.
Еще где-то звук был. Вот сюда вот щелкаю, чтобы звук включать, отключать.
Где?
Вот на эту вот обычно щелкаю. Вот на вот эту вот. Вот на эту.
Так я вот это сейчас в ней.
Ну хорошо. Ну давайте начать эфир.
Начать эфир.
Ну все, попробуем.
Сейчас.
Ну что?
Иду. Сейчас тут получилось.
Получилось?
Ну, да, тут
Ну все,
сразу.
давайте я начну.
Уже время лекции скоро закончится.
А что вы делаете? Зачем она мне нужна?
Вот. Чтобы вы не видели ее. Блин, она опять развернулась.
Так нас же уже слышно, я так понимаю.
Да.
Вы же хоть не ругайтесь.
Я ничего не.
Ну все, я справлюсь. Спасибо. Здравствуйте, уважаемые студенты. Извините за задержку. К сожалению, это связано с техническими проблемами. Пожалуйста, регистрируйтесь в чате, и мы с вами начнем лекцию на тему пневмонии. Пожалуйста, жду ваших ответов в чате. Pneumonia is defined as inflammation and consolidation of the respiratory part of the lung tissue alveoli due to an infectious agent. Please, dear students, check in the chat and listen to the lecture. I am sorry for delay. It's due to technical problem. Now we already start. So pneumonia is inflammation of the lung, mostly inflammation of the alveolus, and may be interstitial pneumonia, but it is more rare situation. And this inflammation is caused by different agents, mostly bacteria, but also can be viruses. What is alveolus? Here is a scheme of alveolus which are surrounded by the vessels. And alveolus used mostly for oxygen and carbon dioxide exchange. In case of pneumonia, bacteria placed in the alveolus and its deposition lead to dilation of the vessels and exudate inside alveoles, which contain pus and bacteria themselves. It's morphological changes in patients with pneumonia. Intrinsic factors that predispose pneumonia include host immune response, the presence of comorbidities, aspiration of oropharyngeal flora into the lung, and local lung pathologies. So you know that around us always present a lot of bacteria, but we don't know where are them, and we very commonly every day inhale some bacteria and exhale it. If concentration of bacteria and viruses is not so high, and if organism has no comorbidities, has higher immunity, patient will not take the infection, person will not take the infection and will be healthy. In bad situation, when patient became ill, or for example, if present aspiration into the tracheobronchial tree, it can cause inflammation of the alveoles, location of bacteria inside alveoles, and development of pneumonia. Classification. We classify pneumonia to community-acquired pneumonia, which may be typical and atypical, and nosocomial pneumonia. There are two main groups of pneumonia which used in all countries. Why do we classify pneumonia to these two groups? Because community-acquired pneumonia is more common, but as a rule has less severe clinical cause than nosocomial pneumonia. Also, some authors may speak about aspiration pneumonia and pneumonia in immunocompromised patients, like in special subgroups of pneumonia. But aspiration pneumonia mostly nosocomial pneumonia, and pneumonia in immunocompromised patient is community-acquired pneumonia as a rule. Typical organisms in community-acquired pneumonia include Streptococcus pneumonia, Chlamydophila pneumonia, Haemophilus influenza. These data are from guidelines for pneumonia, which last guidelines for pneumonia in the United States was made in 2019, so before development of COVID-19 epidemic. So here, no coronavirus. Really now, in case of community-acquired pneumonia, a lot of cases take coronavirus infection. And now coronavirus infection takes around 20%. 20%. It doesn't mean that coronavirus pneumonia is the most frequent type of pneumonia. No, still bacterial pneumonia is the most frequent. Even in our hospitals, when we hospitalize all patients together, all patients with pneumonia, I mean, only in 1/4, 1/3 of them present coronavirus. Others are suffering from bacterial pneumonia. And today our topic is not for coronavirus. Of course, I'll mention about this problem, but mostly we'll discuss bacterial pneumonia. It doesn't disappear, and we have to know how to manage this patient also. How do pneumococcus look like? It may be visible by microscope. They are bigger than viruses and no need to do some immune assay to reveal them. That's why it's more easier to make diagnosis of bacterial pneumonia. More rare bacterial pathogens in community-acquired pneumonia are Klebsiella, Staphylococcus aureus, and Pseudomonas aeruginosa. But these microorganisms very commonly are more resistant to beta-lactam antibiotics. That's why more difficult to eliminate it. And if difficult in treatment of community-acquired pneumonia, and we are sure that it is not viral, that it is bacterial pneumonia, we have to suspect this microorganism and use some specific antibiotics for it. How do Klebsiella pneumonia on sputum grass strain look like? It's bacteria which looks like small sticks. Maybe atypical pneumonia and atypical pathogens are Legionella, Mycoplasma, Coxiella, Chlamydia, and viruses. It's from previous guidelines, 20-25%. It's different viruses, flu viruses, for example, rhinoviruses, and other if we include in these viruses coronavirus, of course, percentage of viral pneumonia in a typical will be more. I feel it is even more than 70-80%. Mostly atypical pneumonia now is coronavirus pneumonia. And atypical pneumonia has some specific clinical cause. That's why we have to remember that coronavirus pneumonia has some specific clinical cause, which not so frequent in bacterial pneumonia. For nosocomial pneumonia, which microorganisms lead to it? Nosocomial pneumonia also is bacterial pneumonia, but in this case, bacteria are more resistant to antibiotics. That's why also more difficult to treat this type of pneumonia. And it is due to Staphylococcus, Klebsiella, or gram-negative pathogens, Enterobacter, Pseudomonas aeruginosa, and Escherichia coli. What can affect clinical cause of pneumonia? Which disease may affect clinical cause of pneumonia? Mostly disease lead to more severe clinical cause of pneumonia. I hope all of you know that coronavirus pneumonia is more severe in patients with comorbidities. Bacterial pneumonia also. For bacterial pneumonia, we have more time to understand what affect its clinical cause. That's why we know better. For bacterial pneumonia, it is diabetes, alcoholism, COPD, and HIV infection. For pneumonia due to coronavirus infection, you already know that respiratory tract disorders, if patients suffer from COPD or asthma, may worsen clinical cause of coronavirus pneumonia. Also, cardiovascular disease, because very commonly in severe clinical cases in patients with coronavirus pneumonia, heart are involved also. And if already present some pathology, it leads to more severe clinical cause. In patient with liver disease, more severe clinical cause. And in patient with immunodeficiency, it may be HIV patient, but not only HIV patients. Can be patient with immunosuppression therapy. For example, patient with autoimmune disease like systemic lupus erythematosus or rheumatoid arthritis. In this case, they usually use drug to suppress immunity. Patient with oncology also use immunosuppression. That's why in all these patients, immunity, their personal immunity is very low, and this patient has more severe clinical cause of pneumonia. Pathogenesis, pathway of infection, may be oropharyngeal flora aspiration, inhalation of aerosol with microorganisms, hematocrit granules, and dissemination from the non-pulmonary source of infection, contact expansion of infection from neighbor organs in case of trauma. Now, more common are inhalation of aerosol and oropharyngeal flora aspiration. Inhalation of aerosol with microorganisms is mostly main pathway for bacteria and viral entrance in the tracheobronchial tree and alveolus. Oropharyngeal flora aspiration also can be, and it is more prominent mechanism in unconscious patient. For example, patient with severe alcoholism who after drinking sleep and don't feel anything. For patient with stroke, for patient with other loss of consciousness due to different reasons. And in this case, aspiration of normal flora, normal bacteria, which are living inside our oral cavity into tracheobronchial tree and alveolus may cause severe pneumonia with specific clinical cause, which is also more severe than community-acquired pneumonia due to pneumococcal invasion. Now I want to tell you about typical clinical cause of pneumonia. Main reason for this typical clinical cause of pneumonia is pneumococcus. In this case, patient will tell you that he suddenly feel bad, that was sudden onset of fever and shaking, chills, dyspnea, pleuritic chest pain and cough with production of sputum. Can be rice-colored sputum. At the beginning, cough may be without sputum, but very fast it will transform to cough with sputum. Rice-colored sputum may appear, may not appear, but usually not in the first day. After 3 to 5 days, it can be rice-colored. And again, I want to repeat you that patient became ill very fast, and dyspnea and cough. Chest pain, not always. Chest pain appears only if pneumonia is large in size and affect pleura. In this case, will be pain during breathing. If pleura is not involved, for this patient, pain is not typical because lung parenchyma has no pain receptors. If you see this patient, you have to do physical examination. And physical examination detects signs of consolidation in percussion and palpation. In percussion, you will find dullness above some part of the lung, not diffuse dullness, only focal dullness above affected area. Crackles in auscultation. More specific auscultation is at the beginning and at the end of the disease. In this case, you may found some specific low-pitched crackles which are typical only for pneumonia. In this patient, you have to send to X-ray examination. In X-ray will be radiological evidence of consolidation. Examination of sputum in case of pneumococcal pneumonia shows gram-positive diplococci in chains. But we'll discuss later which methods are more obligatory, which less. Radiological examination is very important and is and should be done in all patients. But examination of sputum, not to all patients. We'll discuss this problem later. And again, I repeat you physical examination. The most important information on physician examination is connected with signs of lung tissue consolidation due to local inflammation. Inflammation of alveolus with exudate inside the alveolus. Dullness on percussion, increased tactile phrenitus, decreased intensity of breath sound, crackles or crepitation at the beginning and resolving of inflammation. Local rails and pleural friction rub may not be. So more specific is crepitation. It's low-pitched crackles, but it lasts only a few hours. That's why you may not find these crackles. And crackles in general at the beginning may not be audible because at the beginning not too much fluid inside the alveolus. That's why you have to believe a patient with cough and high temperature that he may be may have severe disease, and send this patient for X-ray examination. If normal X-ray, send him to X-ray again. And for today practice, when coronavirus is very common, we have to think about viral infection, which is not so visible in X-ray, and send this patient to CT scan. We'll discuss it more. We'll speak more about it later. What about clinical picture of atypical community-acquired pneumonia? Most patients present with a gradual onset of the disease without shaking chills. A prodrome of it consists of headache, photophobia, sore throat, mild diarrhea, and eventually a dry, non-productive cough. Although these patients were not feeling well, they were not critically ill. Laboratory evaluation shows white blood cell count may be normal. Pulmonary intent rate on a chest X-ray, not always. And I already told you that viral pneumonia is, as a rule, atypical. The severity of viral pneumonia depends on patient's organism, first of all, patient's age, patient's comorbidities, drugs which patient usually use. And may be high temperature for coronavirus. For severe coronavirus infection is typical high temperature, but my patient may be even asymptomatic or has subfebrile temperature. The onset of coronavirus disease is not so sudden like the onset of bacterial pneumonia. Even fever not in one day develops. It starts gradually and increase day by day. Also, there are some symptoms from other organs. For example, can be diarrhea, can be loss of smelling, for example. So nervous system is affected, gastrointestinal system may be affected. So for atypical pneumonia really is typical affection of other organs except respiratory system, other organs involvement. And the most closely clinical picture of coronavirus pneumonia is to influenza pneumonia. But fortunately, both influenza and coronavirus not always lead to pneumonia. If patient develops severe community-acquired pneumonia, CAP, it means community-acquired pneumonia. I will use this name for this disease, CAP, community-acquired pneumonia. Severe community-acquired pneumonia has criteria major and minor criteria. Major criteria is invasive mechanical ventilation and septic shock requiring vasopressors. What severe community-acquired pneumonia due to coronavirus also need invasive mechanical ventilation and vasopressors for many patients. Minor criteria: hypothermia can be, partial pressure of oxygen, ratio of partial pressure of oxygen to Fi of oxygen less than 250. Leukopenia can be, not always, but can be. Multilobal infiltrates, which is typical for coronavirus pneumonia. Confusion, respiratory rate more than 30 breaths per minute. Uremia, thrombocytopenia, and hypertension requiring aggressive fluid resuscitation. So we are speaking about severe community-acquired pneumonia because will be different treatment for non-severe and severe community-acquired pneumonia. For example, for non-severe and severe community-acquired pneumonia due to coronavirus infection. The diagnosis of pneumonia is impossible without X-ray investigation. X-ray is main method in patient with cough, with chronic cough, and in patient with cough and fever. Direct indication for chest X-ray is not only focal acoustic pathology, but also any clinical situation accompanied by chronic or prolonged cough. If cough lasts, for example, more than 1 week, more than 10 days, you have to send patient for X-ray investigation, even if he has normal temperature. There are many reasons of cough, and we have to use X-ray for differential diagnosis. As you know, for coronavirus pneumonia, there are no specific changes in X-ray, but may be cough due to bacterial pneumonia, which is very good visible in X-ray. So even for differential diagnosis of these two types of pneumonia, we have to send patient to X-ray. But I again want to repeat you that mostly, even nowadays, patients suffer from bacterial pneumonia, not from virus. How does it look like bacterial pneumonia? X-ray, changes in X-ray are typical for bacterial pneumonia. Here you see left lower lobe pneumonia. In the left side of X-ray, you see homogeneous shadow, which is big in size, spread from peripheral part of the lung to the central part of the lung, and it is intensive, and we can easily to differentiate affected part from non-affected part. Right upper lobe pneumonia. Here, very clear, visible that only one lobe is affected, and shadow, intensive shadow, which takes big size of the lung, and it is bacterial pneumonia. It is typical X-ray for bacterial pneumonia. And middle lobe pneumonia. In middle lobe pneumonia, middle lobe not so visible in frontal X-ray. That's why we have to add X-ray examination from the left or side of the patient. And in this case, you see triangle shadow which characterize middle lobe pneumonia. Aspiration pneumonia. I already told you that aspiration leads to non-specific clinical cause of pneumonia because there are another microorganism, not pneumococcus. It's mostly gram-negative bacteria which are living in our gastrointestinal tract. And in case of aspiration aspirated particles and which contain bacteria spread to both sides. So both lungs are affected and many foci present. And in time, these foci may be abscess formation, very typical for aspiration pneumonia. And now I want to show you X-ray from patient with coronavirus pneumonia. You see there are some shadow, but mostly the foci are small and they localized in the peripheral part of the lungs. And they are not so clear what is it. That's why X-ray is not specific type for diagnosis of coronavirus pneumonia. And in this X-ray, it's not mild pneumonia, it is moderate to severe. It may be moderate to severe pneumonia due to coronavirus infection. Because mild pneumonia will be even absolutely not visible. Because for atypical pathogens, which include viruses, is specific affection of interstitial tissue. That's why X-ray may not show it so clear. In bacterial pneumonia, there is focal pathology, which is big in size, and it is very clearly visible in X-ray. So I will repeat again. X-ray is obligatory in patient with cough and temperature in whom we suspect pneumonia. But for viral pneumonia and for other atypical pathogens pneumonia, it may be normal. That's why we have to do CT scan. CT scan is a rule not necessary to do in case of bacterial pneumonia. And nowadays, when we need CT for patient with coronavirus pneumonia, no need to send all patient, especially patient with proved bacterial pneumonia for CT scan. It is already visible in case of X-ray examination, which is cheaper and more available for many persons. But I put this picture here for you to help you to differentiate CT picture of bacterial pneumonia and coronavirus pneumonia in your patient. Again, CT in case of bacterial pneumonia. Yeah, you see big size of infiltration, focal infiltration, and also you can see bronchus inside the infiltration. Everything is not typical for coronavirus pneumonia. For coronavirus pneumonia, present peripheral pathology of the lung, multiple pathology of the lung, and affected as a rule both lungs. So-called ground glasses in patient with pneumonia. You see here ground glasses, here ground glasses, here in the cortical layer. So both sides are affected and not so intensive schedule, mostly localized in peripheral part. More advanced stage of coronavirus pneumonia not only ground glass. Ground glass already became more prominent and in present consolidation, but again, mostly affected subcortical layers and affected both lungs. But you should remember that ground glass are not specific or only for patients with coronavirus pneumonia. It may be seen but even in bacterial pneumonia in initial stage of the disease. So ground glass in CT is not enough to make diagnosis of coronavirus pneumonia. You have to do laboratory investigations. Now it is time to do break, but I hope you will agree with me that better to continue lecture without break because it is too late now. Let us continue without break. Please type me in chat. I give you 1 minute. Do you agree to continue lecture without break? Please answer to my question. I give you 1 minute for answer. Minutes for answer. Okay, let us continue. So we'll continue with laboratory investigation. Of course, the most cheap is complete blood count. and it is recommended for all patients with suspected pneumonia, independent. Is this pneumonia coronavirus pneumonia or it is bacterial pneumonia? C-reactive protein. It's recommended for inpatient. Urea, creatinine, and electrolytes, alanine aminotransferase, asparagine aminotransferase, bilirubin, glucose, only for inpatients. In case of pneumonia, there are no specific signs of inflammation, and it is leukocytosis, shift to the left, and high ESR incomplete blood count. Why we don't do C-reactive protein for all patients? Because not necessary. X-ray usually very sensitive, and to check severity of inflammation may be enough to do complete blood count. But for more severe cases, we have to check C-reactive protein. Also, we have to do it for differential diagnosis of pneumonia with other lung pathology if you are not sure in diagnosis. Urea, creatinine, potassium, sodium, alanine aminotransferase, asparagine aminotransferase, bilirubin, glucose, you have to check for comorbidities mostly, for involvement of other organs. In severe clinical cases, coronavirus, for example, may affect different organs, may affect heart, may affect liver, may affect brain. So in this case, absolutely necessary to check other organs function. That's why you do more broad spectrum of analysis. And before we discussed about sputum culture, it was from previous guidelines. The newest guidelines from United States, from which was made 1 year ago, didn't recommend sputum culture for all patients because sputum culture is very good if there are pneumococcus inside the culture. They have some specific appearance and we can recognize it. But if there are some flora which normally may be in oral cavity or in tracheobronchial tree. For example, if there is Klebsiella or can be gram-negative, some gram-negative flora, it may be in healthy persons also. We have a lot of bacteria in our oral cavity and gastrointestinal tract. And even if you see it in sputum, it doesn't mean that these bacteria cause pneumonia. Maybe pneumonia is due to viral infection, for example. So sputum culture very commonly leads to mistakes. That's why now in United States it is not recommended. But Gram strain instead of it may be done culture of low respiratory secretion and blood culture. But it is also not recommended for outpatient, which has non-severe clinical cause for infection. For outpatient with non-severe clinical cause, main reason for pneumonia is pneumococcus, and it is sensitive to beta-lactam antibiotics, to broad-spectrum antibiotics. That's why not necessary to do additional examination, to send patient to different laboratories. Let him be at home, take rest, and take medicine. Mostly more than in 90%, this medicine will be affected. In the hospital, Gram strain culture of low respiratory secretion and blood culture should be obtained if patient. So if patient is hospitalized, it means that pneumonia is moderate, severe, or very severe. So may be necessary. In many cases of hospitalized patient, we have to know microorganisms which cause this disease. For viruses, it will be not helpful. We are speaking about bacteria because viruses you will not find in the culture of low respiratory secretion or blood culture. But for bacteria, we may find them there. And we have to check this culture in patient who are classified as severe, patient with severe community-acquired pneumonia, especially if they are intubated. If patients are being empirically treated for methicillin-resistant Staphylococcus aureus or Pseudomonas aeruginosa, severe infection which is not sensitive as a rule to penicillin, were previously infected with methicillin-resistant Staphylococcus aureus or Pseudomonas aeruginosa, were hospitalized and received parenteral antibiotics in the last 90 days. In this situation, microorganism, high probability that that microorganism which cause pneumonia is not pneumococcus. That may be some resistant microorganism, and in this case we have to reveal which microorganism cause pneumonia. We start treatment. Before starting treatment, take analysis, then start treatment with broad spectrum antibiotics. And after a few days, when we receive analysis and know which bacteria cause pneumonia and its sensitivity to antibiotics, we may use some special groups of antibiotics. Later, I'll tell you which antibiotics we have to use in most common situation of community-acquired pneumonia and in special situation, for example, in case of methicillin-resistant Staphylococcus aureus. There are very interesting tests for bacteria. There are urine tests for pneumococcal and Legionella antigens. It was like revolution a few years ago that no need to do sputum examination, no need to do to take blood samples. We may check antigens of pneumococcus and Legionella in the urine and very fast reveal this infection. But it is only for 2 microorganisms and it is not so commonly spread. That's why American Association not recommend routine testing urine for pneumococcal or Legionella agents except in adults with severe community-acquired pneumonia. Again, not necessary in case of non-severe community-acquired pneumonia of bacterial origin. And I told you that these guidelines, even the newest guidelines for pneumonia, was developed before before we know about coronavirus. And in this case, they spoke about influenza. And it is very interesting. What do they recommend? They write that when influenza viruses are circulating in the community, we recommend testing for influenza with a rapid influenza molecular assay, influenza nucleic acid amplification test, which is preferred over a rapid influenza diagnostic test, so antigen tests. So, if epidemic of virus infection, maybe influenza, now coronavirus infection, they recommend to prefer PCR over ELISA test. And the same for coronavirus infection. You know now that PCR is more sensitive and recommended more commonly for this situation. What about C-reactive protein? It is very...
Это уже надо, да.
Давайте уже. Пусть все отдохнут.
Это будет теперь не такой попадание.
А вы теперь все время будете?
Да нет, Дима там на конференции.
Ну, Дима, у него компьютеры лучше слушаются. Знаете, каждый своего, вот как собака привыкнет к одному, так и к ним тоже.
Это все запороло, по-моему.
Ладно, до свидания. Ничего страшного. Студенты будут счастливы.
Если будут счастливы.